asking where name is there, all இல்லன்னு இப்பதான் பேசிட்டு இருக்கோம்.
இப்பதான் லேப்டாப்பை செட் பண்ணிட்டு இருந்தேன்.
ஓகே ஓகே.
செட் பண்ணி முடிச்சுதான் வீடியோ ஆன் பண்ணாங்க.
சரி
கேட்டுட்டு இருந்தேன் நீங்க பேசுறதெல்லாம்.
I think we are live. Sandhya,
Sujata.
go ahead.
Hello, madam.
Sandhya,
Hello.
Sandhya there.
Yes, ma'am. Yes.
And then we are live now. Let's go ahead.
Sandhya, unmute yourself.
Yeah. Very good afternoon to everyone. And I welcome you all on behalf of Pune OBGYN Society for yet another webinar in the Cutting Edge series. And today's webinar is with Kanchipuram and Theni Society. So I request, I welcome everyone on POG's behalf. And I would request Mr. Prasad to play the prayer song and then we can proceed forward.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Mr. Prasad, for the prayer. And I would request our General Secretary, POGS, Dr. Meenakshi Deshpande, to say a few words. Actually, our President, Dr. Aarti Nimkar, she's traveling. So on behalf of her and on behalf of POGS, Dr. Meenakshi Deshpande, our General Secretary, would say a few words. Over to you, Meenakshi, ma'am.
Yeah, thank you, Dr. Sandhya and Dr. Vaishali. Actually, as a Secretary of POGS, I would like to welcome all the faculties today and the guests of honor. I'm presently, even I'm on the road, I'm traveling, but I can join when I'm on the road. That's why I told her yes. And I hope all of you really support Dr. Vaishali Chavan as our, Foxy Vice President. She will be standing for the elections now. Next year, she has already declared a candidature. And I really hope you all support her wholeheartedly. Thank you so much. And I really like to welcome you to this platform of POGS today. And this webinar of Cutting Edge was started by Dr. Meenu Agarwal. And so we are really thankful to both of them for continuing. Yes, Dr. Sandhya, you can move forward.
Thank you, Meenakshi ma'am, for your kind words. I would request Dr. Vaishali Chavan to please say a few words.
Thank you, Sandhya. I would like to thank, I'm totally grateful to Kanchipuram Society and Theni Society for doing this webinar with Pune Gynec Society. And so very grateful to Dr. Charmila, who is the busiest Vice President Foxy, but she immediately said yes for this webinar and she joined as guest of honor. And Dr. Varsha Baste madam, our second guest of honor, who will soon join. And I am really indebted to you, Dr. Charmila, because you're not only a dear close friend who's always encouraging, but you have inspired us and me and all of us so much. Not only are you academically the boss, the master of everything, but you're such a great, close, big-hearted person, such a good person. And your warmth and friendship means a lot. And at your great stature, we are totally inspired by you. And thank you to Kanchipura Society, to Dr. Chakravarti, Dr. Umayal, and to Theni Society, Dr. Seema, and our chairpersons, Dr. Sujata, Dr. Nivedita, Dr. Renuka, and of course, our own Pune OBGYN Society, Dr. Aarti Nimkar, Dr. Meenakshi, Dr. Amol, and of course, Dr. Meenu Agarwal, and our youngster, Dr. Sandhya, for coordinating and organizing. Sandhya, I think we can proceed further.
Yes, ma'am. Thank you. I would request Dr. Meenakshi Deshpande to officially introduce Charmila ma'am so that we can go ahead. Meenakshi ma'am, are you there?
Yes, I will introduce.
Yeah.
Dr. Charmila, how are you? Thank you so much for attending our webinar here. And I would like to introduce you. She is Vice President of FOXI 2024, Vice President Trichy Obstetrics and Society. She is Chairperson of the Clinical Research Committee FOXI 2016-18. She is the ICOG Governing Council member from 2021 to 25.
It's okay. I think her connection is the same.
Ma'am,
Sakshi, are you there? I think our
he's-
connection is, so
Yeah,
we
yeah.
all know Dr. Charmila. She is a very charming, that's what they call her always, lovely and a great academic figure, Vice President FOXI 2024, Vice President Trichy OBGYN Society, Chairperson Clinical Research Committee, FOXI, when she did a lot of work in the committee, ICOG Governing Council member. And I have seen Dr. Charmila working in UNICEF, FOXI, PCA, MEDA FOXI PG program, ISAR Gurukul program, she's been national coordinator of all this. And especially during COVID times, the amount of work she has done for UNICEF, FOXI, PCA is really tremendous work. She's series convener, ICOG Journal Club and ICOG certificate courses. WHO Southeast Asia region, MDSR India member, President Menstrual Hygiene Management Consortium 2018 to 20. And I think that was a record program which you had done, Dr. Charmila. Simultaneously, at the same time, you had carried forward this awareness program all over the country. And we all remember that. Secretary Gestrosis India Association, Academic Wing of Assisted Reproduction, Trichy, Managing Member, PCOS Society of India. So welcome, Dr. Charmila, and we would like to hear from you and receive your wishes and blessings.
Thank you so much, Vaishu. I don't think I deserve so much of this thing from you. We have always been great friends. And it's always an honor to be in a program where you are one of the organizers. And I know Meenu did the same programs last year and it was a resounding success. And I hope it will continue for the future also for your work also. And I'd like to thank Dr. Meenakshi Deshpande for joining the program and giving the introduction. And I'd like to thank the President, Dr. Aarti, Dr. Meenu Agarwal, the past president, and of course, Dr. Vaishali, who's been the past chairperson of the Perinatology Committee. And I would like to re-emphasize what Dr. Meenakshi was saying. People who are very hardworking and who have got something to say to society, something to work for society should always be elected. And Dr. Vaishali Chavan is a very, very deserving person. And as far as we are concerned, friends for you from South will always be there for you, Vaishu. It's always guaranteed for you. And I'd like to thank the other speaker, Dr. Umayal, for joining. She's a secretary of Kanjivaram Muji Society and a very, very hardworking person. And as we were talking, she did one of the most successful conferences for us in 2024, and it has been acknowledged by Dr. Jaideep Tank also during the managing committee meeting in Mumbai. I'd like to thank Chakravarti sir for all the help he has done and for chairing these sessions today. Dr. Seema, Dr. Sujata have joined in, as well as the other chairpersons, Dr. Nivedita from Teni Society and Dr. Kritika. I'm sorry, Dr. Renuka. And as we said, Dr. Sandhya is one of the most hardworking coordinators, I would say. She made it so much very, very easy to join, and she made sure that all of us joined in time also. I would like to thank all of you for this opportunity and wish Vaishali the best for all her future endeavors. We are there for you, Vaishu. Thank you so much.
Thank you,
And
Dr.
please help Umayal also. She's also going for elections next year. And
Yes.
it should
Thank
be
you,
a
thank you,
mutual.
Charmila.
Yeah,
Yeah.
thank you.
Surely, surely, definitely. Thank you for your wishes. Charmila can't say blessing, we are same age.
Yeah.
But thank you for your wishes and means a lot to me.
Yeah.
And you're truly very, very inspiring to us. So
We will do the best, Vaishu. That is assured.
thank you.
Thank you, ma'am. Our next esteemed chairperson, Dr. Varsha Basti, she is not able to join. So I think we'll start with the first session. As soon as she joins, we can introduce her and then she can give her wishes. Is that okay, ma'am?
Yes, yes.
Yes. So, with this, we begin with the first session. For the first session, I request Dr. Meenakshi Deshpande to introduce the two chairpersons for today, Dr. Seema Gautam Madam and Dr. Sujata Madam. They are both from Kanchipuram Society. So, I request Meenakshi Madam to please introduce them officially.
Can you hear me?
Yes, ma'am, I can hear you. We can hear you.
I introduce the chairpersons.
Hello, ma'am.
We are having the first chairperson, Dr. Seema Gautam, who is MBBS DGO and she's working in Savai Mansingh Medical College. Can you hear me, Sandhya?
Yes, ma'am. Yes, ma'am. You're clear. You're audible.
I am a resident from Hindu Mission Hospital, and she's got a professional experience of more than 25 experience with special interest in managing high-risk pregnancy. Membership, she is a member from Indian Medical Association and also from Kanchipuram Obstetrics and Gynecological Society. So welcome Dr. Seema Gautam Madam to our webinar. And we have got a second chairperson, Sujata. She is from Government Medical College, Nagpur. She is highly experienced obstetrician and gynecologist with 25 years of experience in managing high-risk pregnancies, deliveries, and gynecological surgeries. She's got a professional experience and working in Ramana Children Hospital, Krompet, Chennai, and private practice of 25 years. She is also an IMA member and a founding member of Kanchipuram OBGY Society. Her areas of interest are infertility and gynec ultrasound. So welcome Dr. Sujata Madam. And over to you, the chairpersons, for our next proceedings.
Yeah, I welcome both the chairpersons and I would request Dr. Sujata ma'am to please introduce our speaker, Dr. Vaishali Chavan, formally.
Good afternoon. Let me at the outset thanks Pune OBGY Society, Cox and TNE Society for giving the opportunity to chair this session. I like to introduce Dr. Vaishali Chavan, who is going to be the speaker of this session. She's going to give a talk on adolescent PCOS, a medical enigma. Vaishali Chauhan, madam, as you all know, is clinical director of Cloud9 Hospital, Kalyani Nagar, Pune. She is the director of Sanvi Clinic, Women's Health Center. She is also the vice president elect of Pune OBGYN Society, chairperson of Perinatology Committee of FOXI from 18 to 20. She is also an honorary general secretary of Pune OBGYN Society in 23-24. She has various publications to her credit, chapters in various books, contributions to many FOXI focus, and chapters in international publications. And awards, she has received many, some of which are Punya Bhushan Award 2017, Samaj Bhushan Award, Vaidyak Gaudak Puraskar, Lokmat Award, and Inspiring Gynecologist, a long list. Let me complete it. Inspiring Gynecologist of West India Award by Economic Times and Times of India, and Legends of Gynecological Award at Kolkata 24. Over to you, Vaishali Madam, for your talk.
Thank you, Dr. Sujata, for your very kind words and kind introduction. And truly honored to have you all on this platform with us today. I would just like to share my screen. And is my screen
available?
So my talk today is adolescent PCOS and medical enigma. And greetings to you all from the city of Pune. And as you know, PCOS has a very high prevalence, 10 to 13%, and of which adolescent PCOS is as high as 6 to 18%. And all that we are going to talk about is related to international evidence-based guideline for the assessment and management of PCOS 2023 guidelines. And these are guidelines from ASRM, Monash University, Endocrine ESHRE, ASRM, and so on. So this is a guideline evidence-based talk. And as gynecologists, we really are worried about PCOS because the prevalence is rising. And what is it? Why do we want to talk about adolescent PCOS? Is because it is little different. The way we diagnose adolescent PCOS, the way we manage slightly differs from the way we diagnose adult PCOS, and the impact adolescent PCOS has in the later generation and the origin of adult origin, of fetal origin of adult diseases, what we call, is all related to adolescent PCOS. So the prevalence of PCOS in Indian adolescents is as high as 9.13%, and this was a very interesting study which was published in Pediatric Adolescent Gynecology Journal, where they said that the prevalence of PCOS in Indian adolescents is 9.13%, and the criteria that they chose. This was a study over involving 460 girls aged between 15 to 18 years of age, and the criteria was, this study defined PCOS as presence of two of any of the three features. Now, what are these three features? First is oligo or amenorrhea, that menstrual cycle related, where there's absence of menstruation for 45 days or less than 8 menstrual cycles per year. The second feature is clinical hyperandrogenism, where the modified Ferriman and Galway, for hirsutism, we know this score. If the score is more than 6, then yes, that is the second feature. And the third is polycystic ovary, presence of more than 10 cysts, 2 to 8 mm. So this was a study in 2011, and since then the guidelines and evidence has totally changed. So today, is it relevant? Diagnosing in PCOS in adolescent is truly very challenging, because at the same time the girls are undergoing pubertal development, and these developments, they overlap with adult diagnostic criteria. These girls may develop acne, may develop mild hirsutism as they are going through the pubertal development phase, and at the same time these overlap with the adult diagnostic criteria. So our aim should be to promote accurate and timely diagnosis, to optimize consistent care, and to improve the health outcomes for adolescent PCOS. The symptoms and how do we diagnose? First of all is menstrual cycle disturbance, which occurs in 70% patient. There could be oligoamenorrhea or even amenorrhea, or as against there could be heavy bleeding also in 10 to 15% girls. Hyperandrogenism is seen almost in 70% girls. Acne is seen in 70% girls. And alopecia is really very rare. So the PCOS is a hormonal disorder, and this is a significant public health issue because it involves endocrine, reproductive, cardiometabolic, dermatological, and psychological features. And the symptoms, as we know, could be menstrual irregularity, excess hair growth, acne, obesity, and so on. So it's really a complex, PCOS has complex etiology. And because in adolescent, there are a lot of challenges which lead to a delayed diagnosis. And because of the delay in the diagnosis, there could be dissatisfaction in late treatment or care for these patients. There are a lot of complications associated with adolescent PCOS, short-term like cosmetic, obesity, bleeding, dyslipidemia, hirsutism, acanthosis, and so on. And long-term like type 2 diabetes, hypertension, sleep apnea, depression, and cardiovascular diseases. So when we talk about PCOS, especially in adolescent PCOS, of course, there's menstrual irregularity. I would like to emphasize on this again and again. Androgen excess, and peri or post-pubertal obesity with insulin resistance and hyperinsulinemia. So diagnostic criteria for PCOS and adult PCOS, there are so many different diagnostic criteria, right from NIH, Rotterdam, European Society, and Androgen Excess Society, where they have said that hyperandrogenism, ovarian dysfunction, and polycystic ovary contribute to the diagnosis. And the NIH, HRA, ASRM, and AES PCOS 2009 give all these definitions of PCOS which comprise of these issues. So this is a typical case, 18-year-old girl coming into the OPD, and she has menstrual cycle is irregular, and she has had lot of weight gain, and there's a family history of obesity, diabetes, and subfertility. On examination, so these are the kind of girls who routinely visit us in our OPD. And on examination, she's found to be obese. She has hirsutism with Ferriman-Golve score of 20, acne is present, acanthosis nigricans is there. So what is our diagnosis? As soon as a girl enters into the OPD, after you examine her, your diagnosis is already ready. You have diagnosed already. So what is the diagnosis? Of course, the diagnosis is PCOS because she has menstrual dysfunction, and she has androgen excess because of the hirsutism that you see, and all these point towards PCOS. So when you talk about adolescent PCOS, is ultrasound important? The message here to be given is ultrasound findings of PCOS are not required for diagnosis of PCOS in adolescents. So when you diagnose a girl who has attained menarche from menarche age till next 5 years, ultrasound should not be used for diagnostic criteria, because multifollicular growth is shows, it can confuse with the adult the same findings as adult PCOS. And secondly, there's inability to do a transvaginal examination for these girls. So the diagnostic criteria in adolescent for diagnosis of adolescent PCOS is menstrual irregularity and clinical hyperandrogenism. So these are the two parameters by which we diagnose an adolescent PCOS, and ultrasound does not have any role in diagnosis of adolescent PCOS. So why adult criteria is not applied to young PCOS? It's because these girls are undergoing changes, and there is a high growth hormone release, and this growth hormone could be released in a pulsatile way. And because of this, there is metabolic features like insulin resistance, increased insulin due to high growth hormone, hyperpulsatile GnRH secretion, decreased levels of SHBG, and all this leads to increase in the ovarian and adrenal androgens. So that is the reason adult criteria is not really applicable to young PCOS. When you talk about menstrual irregularity, so what do you mean? It means that within 1 to 3 years of post-menarche, if the period is less than 21 days or more than 45 days, then yes, there is menstrual irregularity. If the menarche has already been attained for more than 3 years, then this girl, if she has cycles less than 8 cycles per year, then yes, she has menstrual irregularity. And after 1 year of menarche, if the cycle is more than 90 days, then that again is counted as menstrual irregularity. Also, primary amenorrhea is defined as by age of 15 years if she does not get periods, or after 3 years of telarche, if she does not get periods, then that is primary amenorrhea. So, is it like today we say incidence is increased for adolescent PCOS? Is it because the diagnosis has improved, or it is the changing lifestyle in today's youngsters, like more screen time, more of sedentary kind of life, more practice in urban India of ordering from outside, eating outside, eating junk food, unhealthy eating habits. So what is it that the incidence of adolescents have increased? Then probably it is both the things: improved diagnosis, and also the changing lifestyle of the girls today. So differential, it's always important in adolescents to rule out other reasons for this, like CAH, non-classic 21 hydroxylase deficiency, androgen secreting tumors, thyroid dysfunction, hyperprolactinemia, Cushing syndrome, exogenous use of hormones, severe insulin resistance, and so on. So how do we manage this? And all of us are familiar that we get these patients and we manage them maybe with MPS or 10 mg daily for 10 days, or microgenized progesterone 300 milligram daily for 10 days, regularizing cycle, because it's important that this girl gets at least more than 8 cycles per year. Combined OC pills, low dose of estrogen, around 30 microgram, along with drospirenone or cyproterone acetate, is also recommended with MPA every month for 10 days. This is for cycle regularity. So cyproterone acetate, drospirenone, desogestrel can be used in association with ethinyl estradiol. And it's important to remember one tip that cyproterone acetate is ideal for hirsute PCOS, whereas drospirenone is ideal for obese PCOS. And we are all familiar with these combined OC pills, progesterone that we usually use for our patient. What about hirsutism? Psychologically, the girls are upset with the hirsutism, excess hair growth, the male pattern distribution, and what are the treatment options that are available for them? Lot of treatment options are there. OC pills, of course, also have with low androgenic progestin, metformin, androgen receptor blockers are there. Such kind of patient needs a multidisciplinary management with obstetrician, dermatologist, maybe a psychologist, and so on. Antidiuretic, spironolactone, which is a diuretic, aldosterone antagonist could also be recommended, and so many cosmetic treatments are available. The patient themselves tell us that, can I go for laser? Can I use this? Acne can be treated by erythromycin, isotretinoin. So these kind of treatment modalities need to involve a dermatologist, need to involve other specialties, and it is a multidisciplinary treatment is what these girls require. Hirsutism can also be treated by lasers, and if that improves the quality of the life of the girl, it reduces her anxiety and depression, then it can be recommended, it can be used. So many oral antibiotics for the acne, isotretinoin are available, chemical peels, and so on. It's important to remember that gynecologists cannot treat all these things on their own, and we do need to involve our colleagues into this. So coming to the medication drugs, there are insulin sensitizers which can be used in adults in PCOS, which directly cause sensitizing of the insulin receptors. And we are all aware about these drugs like metformin, which reduce insulin resistance, decrease hyperandrogenemia, decrease lipid level, helps in weight reduction, promotes ovulation. Also, many other insulin sensitizers like D-chiro and inositol is something which we commonly use, and yes, it is recommended. Myo-inositol is precursor of inositol, and it helps in regulating many hormones, TSH, FSH, and insulin, and it is also a quality marker for oocyte evolution. So myo-inositol is shown to be effective in PCOS treatment by improving insulin resistance. Myo-inositol also has a peripheral component and acts on muscle tissue and adipose tissue. So metformin with myo-inositol has shown to have lot of clinical effect. Now coming to the main part, that is the lifestyle modification, and probably that is what is going to solve our problem, and that is what is the crux of the treatment. Education, counseling, appropriate tailor-made counseling for each individual, a healthy lifestyle, especially for overweight PCOS, low carbohydrate diet, low calorie diet, a balanced nutrition diet, exercises, step-up exercise, decreasing the sedentary behavior, behavioral strategies, and psychological counseling. Because these young girls, they have body image concern, anxiety, and disordered eating. And goals should be such that they should be smart goals, realistic, achievable goals, and time-bound goals like a dietary deficit of 500 calories, 300 minutes of moderate exercise, and emphasis on losing 10 to 5% weight. If that particular girl was 80 kg, and you tell her to reduce 10%, that is 8 kg, that is achievable. Or if you tell that girl that even if you lose 5% of your weight, that's 4 kg, is going to change your menstrual cycle and it's going to reverse all these hormonal imbalance, then they listen to us. and dietary deficit exercise are what is recommended for these people. So for these youngsters, they need a gynecologist, endocrinologist, dermatologist, maybe a diabetologist, and so on. Now, coming to the second part, why is it important that we should treat these girls? Why should we correct hormones in adolescents so that when they grow up and they get married and before planning conception, this PCOS needs to be controlled, because there is something known as fetal origin of adult diseases. The exposure of the in utero fetus to excess androgen leads to fetal origin of adult diseases. And there is lot of research articles and lot of publication which supports there's an association between PCOS and pregnancy loss. And this could be associated there could be obesity, hyperinsulinemia, LH hypersecretion, hyperandrogenism, and thrombophilia. All these things lead to increased pregnancy loss. Also, children born to mothers with PCOS or CAH have excess androgen, and they develop PCOS like phenotypes, and later on cardiovascular neoplastic diseases later on in life. So it is important that we treat these young adolescent girls early, we manage them, we counsel them, and we counsel the family. Not only the patient, but the family needs to be involved so that we can manage this big looming the problem which is ahead of us. And the goals of management of adolescent PCOS is improve the clinical manifestation of irregular cycle, obesity, improve health-related quality of life. And the short-term priority of adolescent is to lower the ovarian androgen by hormonal suppression. Insulin sensitivity can be addressed to decrease long-term complication, address the psychological issues, and it is our duty as obstetrician gynecologist to help her to transition into adulthood and address the problem of subfertility, which may happen later on. So future goals include prevention through timely identification of high-risk pubertal girls and through lifestyle modification. With this, I would like to end my talk. Thank you very much.
Could I request Dr. Seema Madam to please give a closing comments?
Good afternoon, everyone. At the outset, I would like to thank the Pune Obstetric Society and the Kanchipuram and the Teni Obstetric Society. Am I audible?
Yes, yes.
Yeah, so Dr. Vaishali's talk was very clear and lucid. And I think the takeaway point is that the PCOM morphology in the scan should not be the diagnosis to, diagnose the adolescent PCOS. That is one thing. And then in that way, I might request the radiology friends that they give the diagnosis of PCOM to the patient, and they come up in our OPD and with great pride they say, "Doc, I have got PCOS." You feel that why this diagnosis has been given to them. And another thing which was talked of about lifestyle modification, which is diet, exercise, and also stress and sleep. These four things I think we should really stress upon, and if required, the parents. We can counsel the parents separately. A lot about the junk food which have got these endocrine disruptive chemicals, which are coming like phthalates and a lot of junk.
Yes.
So all that we should be really careful, because it is a current epidemic which is going on in our country. So I think efforts are required. Everyone has to just chip in, because all obese are not PCOS. Apart from all those lifestyle diseases which we are having, we're also having these adult PCOS, to deal with. So I think thanks. It was a very nice, lecture which you have given. And if you have questions on the chat box or panelists, if you want to comment. Dr. Sandhya will take over.
Yeah, thank you, ma'am.
Thank you for your expert comments. And truly, these patients come to us with report, and our radiologist colleagues should stop labeling a 15-year-old girl or 14-year-old girl as PCOS.
Yes.
So, yes,
they are very confident. If you say no, that this is they don't believe us. They say, no, I am diagnosed with PCOS. What can you do for me? So you keep telling them. So that is the thing, we should be very careful in writing them, because you can write at best, we can say at risk to develop PCOS. Now, you know, in the one visit, if you see this and you just tell them that you are PCOS, it is quite enduring. It's very difficult to take it.
Yes, yes. Rightly said. Thank you, ma'am. Thank you. Dr.
Thanks a lot.
Umail, Dr. Umail, would you like to say anything?
Yeah, that was an excellent talk, Vaishali, as always. And Seema's point also was very forthcoming. As you say that what we are seeing is only the tip of the iceberg. There's a huge population who is so focused on how to look slim, how to look beautiful, and all these patients have issues of PCOS. So it's up to us to correct them and guide them properly, and tell them that good diet and exercise definitely plays a better role than taking medication alone. So counseling plays a big role in these patients, along with the medical management.
Rightly said. Tip of iceberg, what we are seeing. Correctly said. Yeah, thank you, Dr. Umail.
So thank you, ma'am. Thank you, seniors, for your valuable inputs. It was definitely enlightening. And thank you, Vaishali ma'am, for a brilliant talk as always. Before we move on to the next session, I would just tell all the participants, I would like to tell that Dr. Varsha Baste, she had joined, but due to some technical glitches, she has left the webinar. But she has given her wishes for Vaishali ma'am and asked us to continue the webinar forward. So she's not there in the webinar anymore. So we can move to the next session now. And for that, I would request our chairpersons to join our first chairperson, esteemed chairperson, Dr. S. Nivedita. She is the co-founder and the consultant at Pranaya Specialty Hospital, Yatush Fertility Center, Theni, and also the managing partner at Gauri Clinic, Kovilapatti. At present, she is the secretary of Theni OBGYN Society, and she has a special interest in infertility IVF. She is a laparoscopic surgeon, also interest in cosmetic gynecology and high-risk obstetrics. Welcome, Nivedita ma'am. Our next esteemed chairperson is Dr. S. Renuka. She is at present the joint secretary of Theni OBGYN Society. She's consultant in Leonard Hospital, Batalagundu, consultant obstetrician in Sri Lingamal Nursing Home, Theni, associate consultant in fetal medicine, BFMC, and consultant in fetal medicine, RIO Children Hospital, and Theni Fetal Medicine Center. She has won various academic awards and has various professional affiliations, like she's a life member of IMA, life member of OGSSI, and FOXY member, ISC OG member. She has a special training in obstetric ultrasound and special interest in fetal medicine and advanced laparoscopy. Welcome, ma'am. Welcome, both of you, and I would request Dr. Renuka madam to introduce our chairperson. Next speaker.
Wonderful. Can we, Madam has joined, can we take Madam's wishes and blessings? Dr. Varsha Baste Madam has joined.
I'm so sorry I couldn't join because of some network issue.
Welcome, ma'am. Welcome, ma'am.
Yeah, thank you so much.
I'll just introduce Varsha ma'am. She doesn't need any introduction, but in short, I'll just introduce her, ma'am. She is a practicing gynecologist and fertility specialist in Nashik since 30 years, director of Baste Maternity Hospital and Pushpa Fertility Center. She has
Enough of my introduction, because otherwise the network will go away. So thank you so much, Dr.
Ma'am, we know, we all of us know as the VP Foxy elect, and she'll be the Vice President Foxy from 2025, and various awards and publications to credit. Welcome, ma'am.
Thank you, admin, for giving me the opportunity to talk in front of this August gathering. Thank you, Vaishali. I can see Umail, my beloved OBGYN Society, Kanchipuram, whole of it, the Nivedita and Renuka and Seema. I can see so many of us, and also the POJs, my next homely society, Meenakshi, and this one, Meenakshi Deshpande. Pusat ka kaun hai? BSV Kulkarni hai, dikh raha hai. Sujata is there. I can see many my faces. Thank you, Vaishali, for giving me this opportunity to talk in front of you all. And such a nice subject you have chosen, most awaited, most desired, most happening subject, and most in subject. And the speakers like Umail and all are so Nivedita. Really, I'm really pleased to attending this webinar, and I wish you all the best, Dr. Vaishali Chauhan. You are the apt person. I know you since long, and you have done so much of work in perinatology. I'm really proud of you. And the subjects today, PCOS and adolescent PCOS, are really apt for every other girl we get is having PCOS, and it is such a the tip of iceberg that we are exploring actually, and we are discussing. It is a must to discuss and highlight and get updates and better treatments for all the gynecologists to get such webinars all and often. I think they are the hit point to get updated and give great good treatment to these adolescents who are confused, and their family and their mothers are most confused. And so it is our duty to give them right treatment, right counseling. And the subjects you have chosen are so nice. As I heard your talk also, Dr. Vaishali, it was really fantabulous, but I couldn't listen it for long because of my network issue. But I give you, I wish you all the best. All the Kanchipuram girls, I know each and every, I can give you the list of the girls who I know. Great dancers, so spiritual, the great teamwork they are having, such a small society. But Umail, you have done really great job of uniting all of them.
So thank you,
And,
ma'am, for those wonderful wishes.
Yeah, and POGS is a grand society. I'm really happy because of POGS I could win, because of Kanchipuram also I could win my election, because you girls only voted for me and make it sure that I will get a victory. Thank you so much. Thank you, Vaishali, for giving me this opportunity to talk at least in front of you, all the girls, my beloved girls. And I wish you all the best. You are the apt person for to be Voxy president, vice president, and also president too. Thank you.
Madam, I am also standing for chairperson of Family Welfare Committee, madam. So require
अरे
your
उमायाली, अरे तुमको आना पद आ जाएगी यार. Where we will definitely
Yes,
support you. You are such a nice person, knowledgeable, and give regards or love to your son also. Thank you, and daughter-in-laws.
Anit.
Thank you.
Anit. Thank you, Varsha ma'am. You coming into the webinar has taken it a notch higher, and your presence has truly enriched us all. And such a big stalwart in the field, and you listen to our talk. Thank you very much.
मीनाक्षी को भी बोलना है. हेलो, शी इज सच अ नाइस गर्ल. ये बहुत एक्टिव है तुम्हारी मीनाक्षी भी देशपांडे.
Yes, yes.
I couldn't talk to her.
And
Okay.
madam we know that madam is a beautiful person in every way. She's so spiritual, so loving, so caring, means she engulfs us in her positive energy, and her love is there for all of us. And not only and all her tips, everything, means she is in a different league, madam, in every way.
It is your
Academically
love.
also.
Because of that, I get more highlighted because of your love, Umail, you and all the Kanchi girls and POGS girls also. Love you all. Wish you all the best. Thank you. Thank you so
ma'am.
much.
We love you too. Thank you, ma'am.
Thank you, Varsha ma'am, for your kind words. Now we move on to the next session, and as I requested earlier, I request Dr. Renuka madam to please introduce Umail madam formally so that we could listen to her talk.
Good afternoon, everybody. At the outset, I would like to thank Pune Obstetric Society and Kanchipuram Obstetric Society for giving me this opportunity. Today it gives me immense pleasure in introducing one of our charismatic and friendly and very outgoing madam, Dr. Umayal Murugesan. She has done her MBBS from Chengalpet Medical College, and did her DGO and post-graduation from Stanley Medical College. She is the founder member of AMA Tambaram, as well as she is a joint honorary secretary of Kanchipuram Obstetric Gynecological Society. She has been the treasurer of AMA Tambaram, and she has so many laurels to her name. She is the managing director of Sri Kumaran Specialty Hospital, and she is one of the best laparoscopic surgeon in that part of the country. Thank you, ma'am. Over to you.
Thank you, ma'am, for that warm introduction. And now to the most discussed topic among us gynecologists. So we are handling women where in a country like India, more than 50% of them are found to be anemic. So we handle them as antenatal women, we handle them as gynecological patients, and so on and so forth. So always a little bit of more information on the drug which might be helping us to take care of these patients is always of interest. So now the iron deficiency anemia, we all know that any hemoglobin level less than 11 grams of 11 grams is supposed to be the defined as anemia, and it is the iron deficiency anemia is the most common cause of anemia during the pregnancy in our country. So coming to the demography and to the statistics, 14% of developed countries and 56% of developing countries, you have this iron deficiency anemia prevailing, and it is supposed to cause 22% of maternal death, and that's a huge number. And over a third of all pregnant women, around 30 million, are anemic. So this is such a huge statistics when we extrapolate into numbers. So now coming to the maternal deaths, estimated maternal deaths due to IDA is approximately 3,26,000. And when it comes to the associated disability adjusted life years, that is the DALYs, it is around 1 crore and 24 lakhs. So in a country like India, these figures when extrapolated is so scary actually. So iron deficiency is there and we are supposed to treat it always. Now coming to the determinants of iron anemia in the woman
Oh,
of...
sorry. Would you like to share the screen, Dr. Umail?
You are not able to see it?
No.
Arun? 1 second. Just a minute, wait.
Yeah.
Just give me 2 minutes. I'll just log off and again I'll do it.
Otherwise, you can keep talking. Dr. Umail, you are speaking so well. I shouldn't have interrupted you.
Ma'am, let madam keep talking. I'll just meanwhile I'll open the slides.
Okay. Now coming to the the diagnosis of anemia. So our most important part is to identify the etiology and then go about handling it. Actually, I was getting the presentation on my screen.
Ma'am, I
Visible.
have shared it. I've shared it now.
Can I manage it from here?
1 second, ma'am. Otherwise, you can just say next. 1 second, ma'am. I'll just try to give the remote control to you. Yeah, ma'am, just try next button. I mean, you press next. I think it will. Have you tried it?
Can you see the screen?
Yeah, I have already shared screen, ma'am. You can just click it because the remote control access I have given it to you, ma'am.
Okay. So now can you see it on the screen, Vaishali?
Yes, yes. We can see the
Visible,
screen.
ma'am. Just once you try
See the screen.
next button, ma'am, so that whether it is changing or not.
Yeah, it is changing. It is changing, no?
No, no, ma'am.
No.
No, ma'am. Otherwise, you tell
Can you
me,
change
ma'am.
it for me?
Yeah, I'll do that. You just say next, so I'll change it.
It is open. Open.
You can go in it.
Yes, thank you.
Ma'am, you are sharing screen. Should I stop?
You are able to see the screen?
No, no, ma'am. Are you sharing the screen or should I continue to share my screen, ma'am?
You share the screen.
Already shared it, ma'am. It is visible on screen now. The same slides are visible now.
1 second. Okay, now can you start sharing the screen?
Okay, I'll do that. Just inform me, ma'am, which slide.
From the first, no?
Okay.
Yeah, this one, let it be this. So as I was telling you, like the iron deficiency anemia across the globe, around even 14% of the developed countries and 56% of the developing countries are still fighting with anemia. And IDA was estimated to cause around 22% of the maternal death, and over a third of all pregnant women, around 30 million women, are always found to be anemic. Next slide. And coming to the Indian scenario, the data, when extrapolated numbers, actually we have around 3,26,000 estimated maternal deaths due to iron deficiency anemia. And DALIS, that is the Associated Disability Adjusted Life Years, we have around 1.24 crores of women suffering from having problems due to the iron deficiency anemia. Next slide, please. Yes, and the determinants of anemia in a woman in reproductive group is commonly because of either a decreased erythrocyte production or due to the exposure and the response to the infectious disease. Next slide. And the pathophysiology of the iron deficiency and the deficiency and anemia in pregnancies. One is the dilutional effect of the blood. Second is the placental development, and third is the fetal recurrence. So all three are, even if the woman is found to be healthy at the start, she goes on to become anemic because of all these factors. Now coming to and this slide actually tells us that the iron requirement for a normal woman is around only 0.8 milligrams per day, but during pregnancy, it is almost increased 9 times. So this again ensures that we have to make sure that the woman should not to improve her anemic status before she becomes pregnant. Next slide. Yes. And all the ACOG and the RCOG suggest that anemia screening in pregnancy should be at least done twice, one in the first trimester and the second between the 24th week or the second trimester or the early third trimester, to make sure that we have adequate time to manage anemia before she comes for the delivery. Next slide. And the diagnosis is it's very simple, it's widely available, and an absolute dependency on hemoglobin concentration lacks adequate sensitivity and specificity for the diagnosis. Next slide, please. Next. Next. And this is the postpartum anemia. So we also have to remember that the anemia in pregnancy, if not corrected, might also make sure that the patient also becomes anemic in the postpartum phase. So that too is very important. So iron deficiency anemia in pregnancy is also associated with occurrence of anemia after delivery of the child in the postpartum period. And yes, next. So according to the WHO, any hemoglobin level less than 11 grams after 1 week after delivery should be considered anemic, and we will have to initiate some sort of treatment. This could be the reasons, previous slide. The reasons could be the unresolved antenatal iron deficiency of anemia or excessive blood loss during or after childbirth. Next. And the complications related to postpartum anemia is that you have the patient is coming to you with common complaints of tiredness, breathlessness, palpitation, and infections, not responding to antibiotics. And her cognitive performance too is getting affected. She may be emotionally unstable. She is depressed. She has emotional outbreaks, and even postpartum psychosis also, they say that anemia could be a precursor. Next. Again, yes. So the approaches, how do we approach this iron deficiency anemia in pregnancy? So one is that the overall demographies, like we will have to take a holistic response management criteria for these conditions. So it could be, it should start with lifestyle changes, dietary modifications, supplementations, pharmacotherapy, and finally the blood transfusion, which is reserved for the most acute case. Next. And lifestyle problem is, of course, like smoking. If the patient is like, we should advise her not to smoke. And also tannins from tea and coffee are also known to inhibit iron absorption from their food. So we can ask her to avoid teas and coffees, especially an anemic patient who is going to be put on oral medications, and also smoking. Apart from anemia, also low birth weight and preterm delivery is also associated with complications. So we should advise strictly against that. Next slide, please. And the nutritional supply also, like how much ever we supply, it is not able to match the actual need in pregnancy, because we know that the demand for iron is almost 9 times more. And so we'll have to keep that in mind when we start examining the patient. Next. So of course, we know the diets, it's basically a protein-rich diet, be it a vegetarian or a non-vegetarian diet. And so, we'll have to counsel them accordingly. And we have umpty number of items, both in veg and non-veg, which has good source of iron. And we'll have to make sure that she's advised to take all this food in abundance. Next slide. And of course, we all know that a food fortified with vitamin C actually helps in iron absorption. So we can always advise her to take some food rich in vitamin C, like lemon or oranges or any colored fruits, so that it will improve her absorption of iron during her course of diet. Next. And next, of course, whatever we advise, be it diet or nutrition, ultimately the demand is so much that we'll have to supplement her. So supplementation is very, very important. So a decrease in serum ferritin and a decrease of hemoglobin of nearly 0.5 is recorded by the end of the pregnancy. So in the absence of supplementation, loss of bone marrow iron stores is triggered in women, and this depletion of iron stores consequently leads to the iron deficiency and subsequently the anemia. Next slide. So how do we manage? The management is actually very simply drawn. So we have a hemoglobin value less than 11 grams. And if the ferritin level, so we do the ferritin level of that patient. And if the value is more than 30 nanograms per ml, then probably it is not due to iron deficiency. It is due to some other cause. It could be the macrosomic anemia or thalassemias and other type of deficiencies. But if the ferritin level is less than 30, it is definitely diagnosed as an iron deficiency anemia, and the treatment will vary according to the weeks. If it is the first trimester, we always prefer the oral management, or very severe, even blood. But the second and third trimester, we have got umpteen number of options, which we will be discussing in detail. Next slide. Next. So, as per the guidelines by ACOG, the oral iron is considered the first line of treatment in iron deficiency anemia. Next slide. The absorption of oral iron increases with increasing dose of oral iron only up to 160 milligrams per day. So higher serum ferritin levels are observed when oral iron supplements are taken between meals or at bedtime. And the dose of oral iron is directly proportional to the improvement. And alternate day dosing of elemental iron is also known to significantly increase the total iron absorption. So we always have to put them on some iron to make sure that the iron levels, the store of the iron is always maintained. Next. And the various formulations, you have the salts, the polysaccharides, the heme iron, the carbonyl iron, and you have the various formulations. But then we also know that the benefits have been widely accessed, and definitely our women, especially in a country like India, definitely need supplementation of iron as early as possible till the postnatal period. Also, it is best we continue. But the iron is the oral iron is also fraught with a lot of complications, mainly the gastrointestinal side effects, because already she's having the vomiting and nausea and hyperemesis and things like that. And so administering iron may not be very fruitful in most of these cases. So most of the time, the patient, though we prescribe 30 tablets, many a times she's not able to continue the course, or she's discontinued, and she remains anemic when she crosses to the second trimester and the third trimester. Next slide. So that's, as I told you, the lack of adherence to the therapy and all these things will not give us the result what we are expecting. Next slide. And of course, the blood transfusion in the extreme cases. So anything less than 4 grams is a very effective method to treat anemia. So in severe iron deficiency anemia or rapid anemia correction in certain clinical scenarios, or when the patients show no response to dietary iron therapy as a last course of management in severe anemia, maybe blood transfusion still plays a role. Still our patients, we are giving iron transfusion, blood transfusion for few of those select cases who are not responding or who come to us very late, that we don't have time to correct them with an injection or a medicine. Next slide. But we know that there are a lot of risks associated with the transfusion, so we also need to be aware of that. Next slide. The next, we come to the intravenous iron therapy in pregnancy, which has been widely accepted by all of us as probably the best management in the treatment of anemia in pregnancy, especially. So we have the various preparations here. The intravenous, we have many preparations here. Next slide. And you have the low molecular weight dextran again. This is the previous. This is the one which is now predominantly used, free of dextran. Next slide. So we have the newer formations, iron formations, where we have the FCM, the ferric carboxy maltose. This is the most commonly used product what we're using now. So FCM is a parenteral iron dextran-free product approved for rapid high-dose iron replenishment, and it consists of a ferric hydroxide core and a carbohydrate shell, allowing controlled iron delivery so that it stays in the system for a long time and keeps delivering iron for weeks and months and even for years. Next slide. So you have this some of the side. No, next slide. Again, these are data across the world, which is telling us about the levels of the hemoglobin which is raised after the administration of FCM. Next slide. Next slide. So ferric carboxy maltose as a therapy is the best iron which is available right now in our armamentarium to treat anemia. So it is a dextran-free parenteral iron and offers rapid and high-dose replenishment of depleted iron stores. So this is an iron complex consisting of a ferric hydrochloride core stabilized by a carbohydrate cell. Next. And it has a low immunogenic potential, which shields it from a high risk of anaphylactic reaction. So this is free of dextran. So that is the main reason that this has got a very low immunogenic potential and free of some anaphylactic reactions. And the design of FCM permits controlled delivery of iron, preventing the release of large amount of iron in the serum, and also permits large doses of FCM, almost 1000 milligrams at one go in a single rapid 15-minute session. So these three aspects of this molecule makes it very highly attractive and very highly efficient. And that is why we probably all of us like this molecule to use it in our anemic patient. Next slide. And also the pharmacodynamics also says that it is a very safe molecule, and you have almost even in an iron deficiency patients, you have the uptake of around 99% uptake, and even in patients with renal diseases, the RBC uptake is almost 84%, 61 to 84%. So even in sick patients, this can be given very safely intravenously. Next slide. And again, this is the mean plasma clearance. So after single dose of 100 milligrams over a 1 minute, the serum iron concentration is peaking at a mean of 15 minutes. So it is very soon seen in the system, and though very and that is the reason the anemia correction is really amazing by this molecule. Next slide. So optimum timing is probably the first trimester is we are not using it for FCM administration. So ideally the second trimester and early third trimester is probably the best time when you can administer this. And in the third trimester, at least it should be done 2 weeks before the expected date of delivery. Next slide. Next slide. So the efficacy of the ferric carboxy maltose is expressed in the form of improved indices of hemoglobin, ferritin, and total iron binding capacity. So all of these three are found to be definitely improving after giving this molecule. Next. So also in postpartum anemia, it is equally effective. Within a period of 7 days or even 14 days, the women are able to achieve the goal of hemoglobin more than 12 grams after the administration of 1 gram of FCM. Next slide. And coming to the safety. So when compared against other IV formulations, the various studies are there to tell us that adverse effects compared to other molecules is not really there for this molecule, especially the dreaded reaction like anaphylaxis are very, very rare. But still, we know that iron as a molecule can cause some reactions, and we need to be prepared and we need to be aware of it also. Next slide. So these are all the various events which can give rise to a headache and hypertension, dizziness, vomiting, hypotension. So all these reactions are commonly seen, and these have to be actually counseled to the patient before we administer. And we also need to have a close monitor on these patients who are undergoing this transfusion. So this 15 minutes of transfusion is a very high dose of iron. So whatever the molecule, whatever the experts say, we as consultants are responsible for our patients. So always monitoring the patients while this drug is being given is very important, so that any side effects can be observed initially, and if necessary, we can stop the perfusion, because it is an intravenous perfusion, so we can stop it as and when we see some complication developing from the patient. Next slide. So this is the PROMISE study with a number of almost 1,800 patients with iron deficiency anemia, so which assess the efficacy and the safety of the intravenous FCM preparations. Next slide. And so, so this actually goes on to say that definitely the hemoglobin, there is an increase of hemoglobin within a 4 weeks period after the administration of FCM. And those patients who are excluded are in the list, like an anemia, other than iron deficiency, very, very poor hemoglobin less than 4 grams, first trimester, hypersensitivity to FCM and other products, and malignancy and iron overload conditions. It's only for iron deficiency anemia that FCM is going to be useful. So it is very important for us to identify what type of anemia this person is suffering from. Next slide. So again, this study also goes on to say that there is definitely an increase of at least 2 grams after the patient has been treated. All the parameters, the hemoglobin, ferritin level, RBCs, all these things, there is a definite increase within a period of 4 weeks after the administration of the FCM. Next slide. Yes, again, this analysis again goes on to say that there is a wonderful increase of hemoglobin after the administration. Next. So again, these are the various studies. Again, going on to show and reiterate that FCM is a safe product and is definitely a very effective product. Next. Of course, comparing of FCM with other products, we know that it is definitely far more superior than the other products. And the duration within which the improvement is seen is also substantially lesser than when compared to the other products, which is used for the treatment of anemia. Next. So again, this comparison goes on to say that FCM is a much better product than the iron sucrose complex. Next slide. Again, the efficacy and the safety. Again, this product is actually very well known, but the basic product, the problem is here is that FCM should be administered within the stipulated time of 15 minutes. So when we adhere to this procedure, we hardly see any anaphylaxis reaction. It is only when the drug goes on for a long period of time, like half an hour or 1 hour, thinking that some people, they will say that we wanted to see if there is anaphylaxis. So we sent in few drops and then we again increase the dose. All those things were not monitored, or there was a blockage, or all these things are probably the main reason why the patient develops anaphylaxis. In my personal experience, I have been giving plenty of FCMs almost on a daily basis. My patients, at least 2 patients a day, they receive FCM, and till date, maybe 3 years back, I had 2 cases. But after then, nowadays the products are very good, and I'm touched. My patients are really very happy after receiving FCMs. Next slide. So these are the side effects I was taking. Commonly, you have the headache, you have the dizziness, you have tachycardia, and if you have a pulse oximetry, it will tell you that the patient is really going to have some problems. So I always put in a pulse oximetry, and there is a BP cuff in place. And so with continuous monitoring for 15 minutes, it is very simple to make sure that the patient is receiving our FCM in a very nice way. Next slide. So to summarize, we all know that the iron deficiency anemia can give complications to the mother. Next slide. To the baby, you have all these things, your preterm, your low birth weight, gestation linked fetal distress, everything. Next, and even anemia for the newborn baby also is supposed to be there if the mother is anemic. Next slide. So, as we have already discussed, FCM is a better choice, as the patient need not have too many visits, lesser pricks, lesser visits, and so probably at the end of the day, it serves to be economical too. Next slide. And so Foxy also recommends FCM when compared to the other parenteral iron preparations. FCM has several advantages and has fewer side effects, and a single high dose administration is possible, and it can reduce the frequency of the hospital visits. This is the Foxy recommendation on FCM. And it also has an edge on other PPAs. So like from among the wide number of preparations, again, Foxy confirms that FCM is the better option for PP. Next. So the guidance that has to be noted on the use of intravenous iron amongst the pregnant women is that since more than half of the pregnant women in India suffer from anemia, defined as hemoglobin less than 11 grams at any time during pregnancy, it is also further classified as no anemia, mild anemia, moderate, and severe. Next slide. So the guidance here also suggests that among the pregnant women, the National Technical Expert Committee on FCM, see, this is on Anemia Mukt Bharat by the Government of India. So the Government of India also is showing keen interest and now is promoting the use of FCM in anemic patients, even in a government setup. So that is very good news. So that all the women, anemic women, if corrected well ahead before the delivery, we know that the morbidity and the mortality of the mothers can be reduced drastically, as we know that is iron deficiency anemia is the single common cause for the morbidity and the mortality of the pregnant woman and leading to the maternal deaths too. Next slide. So guidance to be noted, as I was telling, intravenous iron may be considered for the management of anemia after ascertaining the cause of anemia. So the moderate anemia, severe anemia, and these are the conditions where it has to be used. And contraindication also has to be carefully notified, like not the anemia not caused by iron deficiency, liver disorders, acute cardiac, so other causes of swelling of foot and other reasons, thalassemia, sickle cell anemia. All these things should be ruled out before you start giving iron. So, and that is why monitoring the ferritin level before we start the iron preparation is very, very useful in the management of these patients. Next slide. So again, these are the guidance amongst the pregnant women, as we have discussed. Next slide. The total iron deficiency dose should be calculated. And you have the FCM preparation is available in 10 ml and 20 ml. Each 10 ml vial contains 500 milligrams of FCM, equivalent to the elemental iron, and each 20 ml is 1000 milligrams. So we can decide on what dose we need to the patient. Most probably the patient, if a patient receives 1000 milligrams of FCM, it actually covers her antenatal period or intrapartum and postpartum phase also. So when we give it in the late second trimester, maybe 20 to 24 weeks we give, and it is very effective. And we see excellent results as far as the patient's hemoglobin has improved, the physical status of the women, her breathlessness improves, and she's able to do some physical exercise on her own. She becomes more active and she starts eating better. And the outcome of the pregnancy also much better. Even the baby's weight there is a weight gain, and the morbidity at the time of delivery also is considerably reduced. And at the end of the day, we have a very happy mother coming and having a very happy labor. And if any subsequent doses are needed, maybe the 7th or the 14th day can be planned for the next dose. And now it should preferably it should be administered at a place where you have some basic monitoring. So basically in a clinic, maybe it is not advisable, but so we have to be in a place where you have some basic setup to manage a rare anaphylactic reaction. If it happens, that needs to be taken into account. And the test dose for FCM is not at all required. So this is again one important take-home message. And once the FCM is given, we just observe the patient for 30 minutes, and then you can ask her to go. Next slide. Yeah. So in a nutshell, iron deficiency anemia is the most common cause, and treatment aspect of IDEA includes lifestyle modification, supplementation, dietary modification, transfusions, and pharmacotherapy. And FCM has demonstrated the therapeutic efficacy for conditions associated with absolute or functional iron deficiency, either with or without anemia. And FCM is reported to be very effective in treating IDA as well as PPA in women. And studies confirm the safety, efficacy, and the tolerability profile of FCM. And Anemia Mukt Bharat guidelines also suggest the use of FCM in pregnant women with IDA. And so compared to other parenteral iron preparations, FCM has several advantages with very fewer side effects. And a single high-dose administration is possible, and it can reduce the frequency of the hospital visits too. Next slide. Thank you. Thank you for listening. And
I request Dr. Nivedita. Thank you, ma'am, for a wonderful elaborative talk. I request Dr. Nivedita to please give her comments.
First of all, I thank Pune OBG Society and Kanchipuram Society for giving me this opportunity to chair this session. And ma'am, Umayal ma'am, as usual, has given excellent talk about iron deficiency anemia and its importance regarding treating the patient in antenatal.
Nivedita not able to hear the connectivity issues.
I think network issue.
Yeah, network connectivity.
Yeah.
Nivedita ma'am, hello. Are you there?
Dr. Renuka is there, I think, chairperson.
Yeah, I request Renuka ma'am to please say a few words.
Thank you for giving me this opportunity. Ma'am has given a brief. In brief, she has given what we need for our practical patient care. And the ma'am has rightly highlighted the neglect.
Really very sorry, ma'am.
Area, postpartum anemia, which need to be followed up. Okay, anyways, let's do the talking.
really very sorry, ma'am, because of my network problem.
Raining also, no, weather also is not good. So everybody's having network.
Yeah, okay. So, ma'am has given excellent talk regarding iron deficiency anemia and the point regarding the correction in antenatal period, and also it will give postpartum period so that to improve the quality of life of the women and also the kids' mental stability, mental development. So take home messages, lifestyle modification. And then oral dose is 160 milligram per day, which is the first line of management. And even after it's not corrected after 4 to 6 weeks, then we can choose FCM very well. And previously, I used to give FCM if the hemoglobin level is beyond 8 grams. And I can see the slide, like even up to 6.5 gram, we can choose FCM very well in antenatal period, 24 to 36 weeks. So very well covered, ma'am. And FCM gives reduced number of visits to the hospital and reduce the number of pricks also. So maybe patient will have more complaints, other treatments. Thank you, ma'am.
Thank you, Vaishali, for
Yeah.
organizing this nice
Dr.
EM.
Renuka was saying something.
Yeah, sorry.
What I wanted to say, she has almost covered everything, nothing in particular. And it was like brushing up for after a long time. We do neglect iron deficiency sometimes. But for me also, it was like brushing back new points.
Definitely. How many ever times we listen to anemia, no, we always get 1 point extra.
Yes,
So-
ma'am, yes, ma'am, very true.
Thank you, Dr. Umail. That was a fantastic talk. Very practical points you gave. Those are more helpful than the detailed theory that how to go about, how to manage patients. And the way you elaborated about your personal experience, like, really, truly enriching for the webinar. Enjoyed your talk very much. And thank you for the practical tips. And I think Seema ma'am is also here. Seema ma'am, would you like to make some comment? You're on mute, ma'am.
Am I audible?
Yeah. Able to listen, Seema.
Yeah, so Vyal ma'am, as always, gives a very nice talk. We have heard her so many times. And this is a topic actually, boring to say, but she made it interesting and she told very nice points. And it was really a revision. So as if we are just going through it. So am I audible now?
Yeah, listen.
Ma'am. Yes, you are audible.
Yeah, it was nice listening to ma'am.
So, very nice talk, Dr. Umail. And it was so good connecting with all of you, Dr. Seema, Dr. Sujata, Dr. Nivedita, Dr. Renuka. Dr. Sujata, you want to say anything? Make any comments on the talk?
As usual, Umayal ma'am's talk was a very good one. And anemia always is a topic which can hear any number of times. Still, we'll have something to add on to it. So it was a very good talk. Thank you so much.
And thank you for all of you to connect with us. And it's a pleasure knowing you. We have met more, but again to connect on webinar, it has been really good. Thank you to Mr. Prasad from BSV. They're always here to help. And our youngster, Dr. Sandhya, is a very good and very efficient and sincere girl. So
Thank
Sandhya,
you. Thank you,
propose a
Sandhya.
vote of-
You called me so many times. Thank you.
Thank you, ma'am. My pleasure.
Yeah.
My pleasure.
Sandhya, vote of thanks. Will you?
Yes. So with this, I would like to propose a formal vote of thanks. So I would like to thank the honorable guest of honors, Dr. Charmila ma'am and Dr. Varsha Basti ma'am for their esteemed presence. Their presence and their valuable inputs have definitely enriched the webinar, and it was very, very enlightening for all of us. I would like to thank the president of Kanchipuram Society, Dr. Chakravarti sir, and president of Theni Society, Dr. Shantavi Bala madam, for allowing us for POGs to do a webinar with them. And thank you for your wishes for the webinar and for Vaishali ma'am. I would like to thank our General Secretary, Dr. Meenakshi Deshpande, for being there throughout the webinar and conducting the webinar and introducing all the chairpersons. I would like to thank the eminent speakers, Dr. Vaishali ma'am and Dr. Umayal ma'am, for elaborative talks and their wonderful presentations. I would like to thank the chairpersons, Dr. Seema Gautam ma'am and Dr. Sujata ma'am from Kanchipuram Society, and Dr. Nivedita ma'am and Dr. Renuka Devi from Theni Society for their valuable presence. A special thanks to Dr. Vijay Lakshmi from Kanchipuram because she has helped me coordinate the webinar with Kanchipuram Society. She was very, very instrumental in giving me all the details. Thank you, ma'am. I would like to thank Mr. Prasad, our academic from BSV, our academic partner, and RX Events, our event management partner, for their always their presence and help for the smooth functioning of the webinar. So thank you everyone. It was wonderful connecting with Kanchipuram and Theni societies, and looking forward to meet you all in more webinars. Thank you so much.
Thank you so much.
Thank you.
Thank you, ma'am.
Thank you and all the best, Vaishali ma'am.
Yeah, Niveda, hi.
Thank you. Thank you, ma'am. And I wish both Umayal ma'am and Vaishali ma'am to get through the election.
Yeah, all the best.
All the best.
Thank you. Thank you. And all the best to you, Mayal.
Yeah, thank you so
for
much.
dinner.
Yeah. We will keep meeting often.
Yes,
again.
we'll keep meeting. See you this weekend.
Definitely.
Yes.
Okay.
Okay.
Bye.
Bye-bye.
Okay. Bye. Bye. Sandhya,